All right, welcome everyone. Wonderful group as always. Before I went full screen here for the presentation, I got to see some of the faces and names. So great to see y'all. Shameless plug for something that I don't benefit from, but hope to see you all in about 7 weeks and maybe 2 or 3 days down in Charleston, West Virginia, for the, as I call, APDAC, but the overall addiction conference down there, of course, a big regional thing for Appalachia. So. All right. Let me see chat wise. So you can see here, it's just people with their names. Okay. That's not for me. So here today, we're going to be going over what I call I think we'd all call naloxone and beyond. So there's some new players in the game when it comes to the medications for opioid overdose. Interestingly enough, or concerning enough, I find, and maybe you do too, but I find a lot of folks out there outside of this expertise that will talk about things like opioid mu antagonists, naloxone and nalmefene, as far as treatment for substance use disorder, opioid use disorder, addiction. And it's like, well, a little bit different there. So we'll dive into some of the nerdy pharmacology, but then also some of the big picture things as well too. That's, everyone here, we all want to be on the same page about. So, all right. Um, Learning objectives start with very low hanging fruit, overdose symptoms. A lot of the opioid mu antagonists will mention the three N's, the whole gang: naloxone, naltrexone, and nalmefene. And then as far as the products and administration guidelines along the way too. So. All right, pretty sure that this is nothing new to anyone here. I'll check the chat again here, to anyone here, but I don't like to skip over any of the low-hanging fruit items as far as, what constitutes an opioid overdose. There could still be discussions out there on well, if somebody's just out comatose, it's like, well, how do you know it's an opioid overdose? So it's really a totality of symptoms overall. We'll dive into some of the clinical pearls in a little bit here as far as, to naloxone or not to naloxone, not quoting Shakespeare. Obviously one of the things would be the death rattle. Unfortunately, I'm sure a lot of folks have heard that before. But, just that slow, rattled breathing along the way. All of these things are very clinical. Not many folks are rolling down any street and they got their steady around their neck, and not everyone likes to touch other human beings either. So, things like pinpoint pupils when the eyeballs are shut. It's a little tricky. Hypotension, um, also bradycardia. I mean, those things you gotta get in there and touch in some way. So that's not always the easiest thing, but things like hypoxia, the blue lips right here or nails, that's something that can be seen from afar as well too. So not that far, but at least appreciable distance away. So things to keep in mind overall. All right, now as far as the administration of the opioid mu antagonist that we have available these days, the two medications for opioid overdose would be naloxone and nalmefene. Everyone's familiar with naloxone, and I'm sure everyone's at least heard the name nalmefene. Don't worry, I know you're on the edge of the seat. I'll show you the structures because the pharmacy nerd has to come out at some point. But as far as the guidelines that are out there, the recommendations for administration, it's really the big picture idea of calling 911 and administering the medication. Different guidelines that are out there will vary based on saying, well, call 911 and then administer, or administer and then call 911. Um, depending on the scenario, it's almost tomato tomato. The big picture teaching point is you got to do both. And this, in my humble opinion, is not to teach anyone here. This is for us to realize when we're teaching others. Because teach the teacher is one of the hardest things out there, particularly when you don't know the ending audience along the way. Oftentimes in say a community pharmacy setting, there'll be a lot of education provided to a patient that, say they're on a higher risk dose of a prescription opioid for pain, and then there's a co-prescribing and dispensing of naloxone. Well, it's not necessarily that person who would be administering it. That person might be the one that's having the overdose. So, it is tricky to, teach someone how to teach in addition to these ideas as well too. So that's why I like to include those along the way. All right, so we have the gang here. Oh yeah. we're getting deep here with structures and pharmacology and all that great stuff. So the only point to this is that these are all very similar. In fact, all the phenanthrene opioids, which is about 80 to 85% of all prescription opioids, have this core structure of these little rings that you'll see on here. Um, don't worry about the ins and outs, of course. I tried to highlight in the bottom right where there's a little subtle, the biochemist out there would have my head, but the subtle changes in the structure just to show the differences there. It's that's not going to help save someone's life, but it's just going to, show the distinguishment there. So the Uber of ride shares or the Uber of opioid mu antagonists would be naloxone. The one that when someone's talking about opioid mu antagonists, that is, they block the opioid receptor as compared to the the actual prescription opioids used for pain and sometimes for opioid use disorder, being agonists or at least partially along the way. Everybody talks about naloxone along the way, so that's why I usually say somebody might be physically in a Lyft vehicle and they'll call it an Uber because it's just how we do it. That's us humans, right? Let's see, more checking in there in the chat. All right, so here's my best attempt at saying here's everything that's available out there and then some. This changes all the time, particularly these days, because there is I used to have a chart that had all the different doses and all that kind of stuff, and it's like, that's too far into the weeds. In the yellow, you've got the injectable products, right? This is only naloxone. Nalmefene will be another slide. But as far as naloxone products that are out there, you got yellows that are injectable and blues in this chart. They're the nasal products. So injectables, you've got a syringe with a vial. Nothing too fancy there. Then you have the 5 milligram product, and these are prescription only. These two options thus far. The Zim High product. That's a little, not a prepackaged product, I guess I should say, along the way. And then you have a little bit less known. There's in the auto injector, the one that used to be $3,950 and would talk to you, is gone as of I think October of like 2022, or it's gone, bottom line. But it's back again. Um, Back again. I think that's Backstreet Boys, if I'm thinking right. Yeah, everybody wants to go to the Sphere in Vegas, right? But anyways, the auto injector is back, but it's only for military utilization. So they keep it in stock in case there's any warfare involving opioids or potential opioids overall. So go figure. Tax dollars. All right, so that's the yellow. Now we're going to jump to the blue, and it's either more straightforward or really complicated. So you have you guys tell me, but typically we see less of the manual kits. You know what? I'm actually for once in my office. These guys that had a lot of times with the orange box or the whatever. There's not an active one in there, but it's there, where you had to put the things together. We see less and less of that anymore. What else do I have up here now that I think about it? Then there's the pre-packaged products that typically I'll show the backside with no label are just the little white injector things for the nose. The difference in the dose, the one thing that folks would want to remember is that if you have to put it together, you also have to spray in both nostrils. Whereas if you have the pre-packaged products that all looks generally the same, that's just spray into one nostril as the total dose, and then it's the usual recommendation to wait 2 to 3 minutes and spray in the other nose if still not revived. That's the difference in the directions overall. We'll come to that pocket naloxone in a moment here, but there's also the availability. Access is a little bit different because that includes cost, but availability would be, just about everything's prescription. But now we have the Narcan, the true Uber out there, available over the counter as well. Take pause with that because that also means that, like, hey, you can get that in like grocery stores, gas stations. Doesn't have to be a pharmacy. Obvious, but important in this realm. There's also and they differ in the dose as well. More to come on that in a hot couple seconds. But we got 1, 4, 8, 3, and 10 milligrams. all available there. There's differences in the dose. We'll touch on that in a moment. So you've got prescription and or OTC, and you got different doses along the way as well too. So not everyone has probably seen some of these products out there. I myself have never seen the 10 milligram. I see as in with my own eyes in front of me. Um, the last one on there is yet to come to market. The NDA, the new drug application to the FDA, was for OTC status, and it's a nasal swab. Think of like a Q-tip, not to downplay their formulation. Instead of spraying, it would be a Q-tip in the nose there along the way. So big picture, you got injectables and you got the nasal sprays. That's pretty much that, but you hopefully can appreciate some of the nuances there along the way. So naloxone itself, again, antagonist, it blocks the opioid receptors in our bodies. Got a couple other things here too. One thing I'd hone in on is the quote unquote half-life, but the duration there of about a half an hour. We certainly see that come into play in I don't know if you want to call it practice or just society, but that does come up. And then I alluded to the access idea. So we went over prescription and over the counter. And back in the day, it used to be where, yes, it was prescription, but then some state to state, our state was one of them that had either dispensing protocols from a board of pharmacy, or there'd be, like we have these days, the standing order from a health officer in the state. But there's also the harm reduction efforts. We've certainly talked about that in previous sessions as well, too. But there's multiple avenues overall. Okay, just checking the chat. All right, so I'm a pharmacist. Hear me roar. One of the things we always consider is what's the dose? So there's a lot of, there has been at least a lot of discussion out there of like, what's the perfect dose? Or, what do you base it on? Y'all that have been here before would recall at some point me and others babbling about MMEs, morphine milligram equivalents, a feeble attempt at comparing opioids for potency. Comes up short in many accords, but it's pretty much all we got as well. So would there be like a reverse MME? Like, oh, well, you got 10 MMEs, so you get this much naloxone. That's, and then when you look at the illicit market, obviously you can't do that because you don't know the dose. But, you know, then we have, I'll touch on here is what's the deal out there with any studies for higher doses? And then what about side effects? I cringe when I hear someone say, oh, this medicine has no side effects. Like literally, they all do. It's a philosophical thing. This substance does things. We say one's efficacy and we say the other ones are side effects as humans. They all come with baggage, but they're dose related as well. And then the last thing here of how many for those in Morgantown, if you go to there's the one restaurant kind of down the road from Applebee's across from the hospitals. As soon as you walk in the door, they say how many because they want to know how many are at your table. It's one of the first things I experienced in Morgantown. It's like, wow, hello, and how many doses, and how many times along the way. So here's some of the more granular things on this dose scenario here for pearls when it comes to naloxone. So about 10 years ago, the FDA convened an expert panel to say, hey guys and gals, figure out the perfect dose. We need this, right? They walked out of the room and said, yeah, you can't do that. It depends on a lot of things, like where the person is, how long is the ambulance ride, what was the original dose that you're not going to know anyway. It just has a lot going on. So since then, we still have attempts at figuring things out like that. So here's a study that you can read the headline there, but of note, this was sponsored by the manufacturer of a higher dose naloxone product. So when you read the title, you might be thinking, oh, that would make sense, right? Um, as fentanyl spread in the drug supply throughout our country, there was this growing concern of needing more naloxone to counter the higher potency fentanyl and fentanyl analogs or carfentanyls and all of the rest of the gang. So this take it for what it's worth, but again, the source is very important along the way. You'll see that again here in a moment with a different study. This is getting nerdy with pharmacology again, but what this K value is the lower the number, aka the higher on this slide, the stronger the magnet to the opioid receptor for that opioid. So sufentanil leads the land, but there's not too many products with that. And then we see buprenorphine. So obviously that's a treatment for opioid use disorder. So a patient that is actively utilizing buprenorphine based on this pharmacological aspect may need relatively a higher dose of naloxone to someone who's not. But it's relative, so we don't really know there. But it's just things to ponder as far as the pearls overall. Then, we have the thoughts of, well, what if someone is utilizing an opioid and then has naloxone so far we're talking about, but now morphine as well. Um, there's obviously the concern for withdrawal. And here we could even think about, what if a patient in pain is on chronic prescription opioids, well managed, balanced out, treatment plan, the whole nine yards, and then encounters something and has an overdose. Well, that's going to be a tricky scenario because there's also other opioids involved there as well, too. If there is no opioid in said person, and then naloxone is utilized, one of the common things that many people will say, technically inappropriately, would be like, oh, well, there's no concerns, there's no effects. Well, it's a substance that's going in a human body. It has its things, right? So perhaps this is one of those little trivia things or fun facts, but technically naloxone or any opioid mu antagonist can treat congenital analgesia, which, to save you the Google, you can't feel if you have that condition, you can't necessarily feel pain, which sounds utopic, but turns out pain also warns us that, like, hey, there might be something wrong and we might get harm. So we need that alarm. And if it sounds like I'm bordering upon the whole, 20 years ago vital sign, is that a vital sign or not? Well, that's for conversations otherwise. But um, this can actually help with that for the like five people on the planet that have it. So, all right, back into the studies. But one of the things was, oh, well, when someone in the directions, it's, say for this, you spray one in one nair and then wait 2 to 3 minutes. And if the person isn't revived, you spray in the other. So there was this study done that said, well, more often than not, folks were needing that second dose, if not more. Well, also of note, this study was founded by the manufacturer of a higher dose naloxone spray and wasn't exactly involving 10,000 people. You could see the numbers here. Hopefully it's three digits, but barely. So, there's that along the way too. And there's also the psychological point where if you're in us, you and I as humans, if we're standing or sitting in front of someone who has just overdosed, is dying, and you give a dose and it doesn't work, I mean, do you get your phone? You're supposed to get your phone out and clock, 2 to 3 minutes. Is that reasonable for a given scenario? It's supposed to be. I'll leave you to answer that. You don't need to in the chat. Just in your head, even. Here's one, though, that stands out as far as the recent studies with naloxone. So we never get head-to-head studies. Until the billionaires enter this health space, we will never get new medicine versus old medicine. Head-to-head, undisputable. You could hear the bells like a boxing or a wrestling match. We just don't get that because companies would it's like betting on roulette, like red or black, I guess. When you're talking millions if not billions of dollars, it's a lot to put on the line. This study, post marketing of course, was a direct head-to-head comparison of 8 milligram compared to 4 milligram naloxone, and lo and behold, what was found was that there was no added benefit for the 8 compared to the 4 milligram. In fact, there was a significantly higher prevalence of withdrawal with the 8 milligram compared to the 4. Perhaps to be fair to the other studies I showed, this was not sponsored by any manufacturer, quite obviously, particularly for the higher dose along the way. So that you can see the dates on there. It's not that long ago, but that was kind of an interesting one. All right, so I hesitate in sharing this information, but you got to be fair and balanced and all that kind of stuff. As far as, well, what about if, is there any side effect concerns? I will start out with these are case studies, not studies, but case reports, I should say, of rather high dose, uh, presumed, offending opioid, the agonist, as you can see here, heroin, and so forth, and high dose naloxone along the way. And in these case reports, there were a few of having concerns for pulmonary edema along the way. So it's a loss to say, hey, there's no concerns overall, but we do have to say what the setting was as well. That's very important along the way. This my one of my think favorite pictures here is Ken. We're humans. We go right to the picture, of course. As reported on social media, apparently I was in the background watching for things. But anyways, this came up on social media once, and I was like, wow, this is a story to share. We're here. I believe we're hearing this less often these days of like, how many times should someone be revived? There was a time when that conversation happened more often. It almost sounds like something that should be taken care of on the weekends in a large building in a large group together or something. But anyways, the if a human was revived 15 times in their life, well, if there was a limit of 14 for payment or use, it wouldn't be there. So, a lot of chronic illnesses have relapse rates that are up there. What if we'd have rescue asthma inhalers or nitro pills, tablets, pills? It's the same concept there along the way too. All right, a little bit further into naloxone here. Let me see the chat. Nope, nothing for presenting here. So expiration dates. Now, I'm not here to say that we should be questioning FDA approved expiration dates. But I am here to say that, well, this particular study that was covered by CNN, I don't have the JAMA, the New England thing. I'm showing the CNN one. And by the way, this was done right here in Wild and Wonderful, West Virginia. It's a decent number of years ago. Um, and by now you're wondering what's the deal with the Mediterranean sea salt there. It's one of my favorite things for talking about this particular expiration date. That sea salt was formed 250 million years ago and expires next month. Really? When you're thinking about all of the programs, the resources, the grants that are out there, and we're out there for providing naloxone via whatever methods, there's a huge loss when it's not utilized. So if there's a longer expiration date that is real, that's important along the way. So this was the original research, and yep, we got it there. I was like, I hope I have the next one. About a year and a half ago, the FDA approved a much longer shelf life and expiration date. Basically, now it's 4 years. Typically, for medicines, we're seeing 1 year, like no matter what, like 1 year or less. So 4 years is really, really notable along the way. All right, one of the last things here. I personally have never watched Mythbusters, but I know of them, so maybe you have watched them. But hearing this a lot less, but we want to make sure to extinguish that fire whenever possible, the whole Narcan party myth. If anybody feels the need to like throw a little like, yeah, I've heard it in the chat, feel free or whatever. Um, so it's a little bit tricky to find some data on that because it's a conversational thing. But the concept would be, in case someone hasn't heard, well, folks just haphazardly saying like, oh, well, we'll utilize opioids with disregard because there's naloxone or an opioid antagonist in the vicinity for just in case. So I found this one resource that was going over that just provided some quotes from healthcare professionals like you and I, just saying like this just doesn't make sense. At some point, it becomes the whole point is avoiding withdrawal, and this medicine could provoke withdrawal. So why would somebody do that? One of the really concerning things is when it's covered by the media. So here's an actual news headline. The aqua colored myth I added, by the way. Obviously, that's not part of the headline, but it says, and it's very interesting, very strategic how it's titled. If Narcan parties are happening, officials say they could skew overdose statistics. Um, well, not a lot of human minds would read if. They will read Narcan parties are, I don't even like saying it, are happening, comma. It's interesting how headlines happen. So food for thought there. All right, in getting closer to wrapping up in respect of our time here, there's also naltrexone and nalmefene. So naltrexone is more so on the oral side. LDN or low dose naltrexone is aimed for utilization in various pain conditions. It's actually been given orphan drug status to help with CRIPS, complex regional pain syndrome as well too. It's also within a weight loss product. Throwing some fun facts out here for you. Bupropion and naltrexone together. It's a FDA approved weight loss product. And of course, things that have been around for decades now, the MOUDs along the way. Last but not least, nalmefene, because this is the naloxone and beyond portion here. So you know, it sounds like it's a commercial for jam or something, but stronger and longer. I tried to summarize a couple of slides down to two colored boxes here, but I'll just say it in words. Stronger and longer. But is that wanted is the question. Here's the nalmefene products that are available. There's two injectables and one nasal spray. And you can see the specifics here. They're all prescription, of course, as that's how they've come out originally. When you're looking at that nasal spray, it's the same looking product, same looking device as the naloxone prepackaged products as well, too. The biggest concern there, and I'd pose to anyone for any discussion or points or questions here or to yourself, would be, the stronger and longer, it still has its concerns for that. There's instances where removing the risk of the overdose reoccurring after the half-hour duration of naloxone on average, observationally, um, that could be a good thing. But then also the stronger, longer provoking withdrawal is certainly a concern as well, too, along the way. All right, key points are just everything. I think it's been a while since we had the starfish, and it is the summer, so I hope some folks have gone to the beach. I didn't this year. We didn't. My family didn't. But um, no matter what we go over on these clinical pearls when it comes to naloxone and beyond, every person that has their life saved, it matters to them in that moment. So it's the age old. I don't know if it's called the story, but the starfish, the one that mattered along the way. So. That is that. I know we have cases coming up, but by all means, questions. I'll kick off the sharing here.
I have a quick question if we have time. Thank you for the presentation. Could you say a little bit about how many in the day and age of xylazine and medetomidine and people reporting that it's taking a lot more doses of Narcan to revive people?
Um, I think it was my internet. It seemed to cut out a little bit there, but so tell me, Jennifer, if I heard that right. Of
It might have been my internet.
needing more doses in regards
Yeah,
to
in
xylazine.
the era when xylazine and medetomidine are
Mhm.
in the
So I'd add in there things, all the fentanyl analogs and all the nitazines and all, the opioid-based products there, really provoking that more so. I really don't want to speculate or add on because I don't have the specific data and it's going to be different state to state. We have some of those summaries coming for our state soon. But, observationally and generally speaking, there has been more of that, but not in a hysteria-provoking way. The drug supply changes. The second that we get our heads wrapped around it's going to change. Xylazine's an interesting instance because it's not an opioid. The naloxone, normal, and nalmefene will do a darn thing to it. It's not going to do anything. It's xylazine. I just figure like think clonidine. It's like a cousin of how it works overall. So that really won't do anything. But to your point, all the other stuff, it's an ever evolving. And that's one of the toughest parts overall. I went into some of that, I think, in a recent podcast that I do, the Pain Pod, but of just this convoluted story overall. And it means the heartbeats along the way. That's the tragic part. So the drug supply is ever changing, and it's presumed that there's trickier parts, but I too would like to see the actual data along the way. And it's always in the past. So
Thank you.
you're welcome. Guys are going easy on me. Just fine, by the way.
Listen, I have a question. So have you seen where they're doing research now where studies show for like how people use the trizempatide, or I might be saying that wrong, like Ozempic and stuff for weight loss
Mhm.
to stop the food thoughts? They're starting to use that with um, drug users to stop them from having like the thoughts with the craving. Have you seen any research on that?
Yes. Has anyone else seen some headlines with that? It's there's more and more information coming out with that. Heck, that conference I mentioned in Charleston actually has a session on that, so I'll be there. See you there. Um, so I'll defer that entire question to Pat, I think Patrick and group. But um, anyways, in reality, one of the things that I would point out with that is that it's always important to read the details. I sound like such an academic, and for once, I'll own it. Um, the studies, at least that I have seen, have been talking about the overdoses. It's kind of like earlier when I alluded to the whole naloxone is not treating OUD, it's taking care of the overdose. That's what we've been seeing. There's more on the alcohol use disorder, that spectrum when it comes to your OOO GLPs, um, in that regard. But within this space, it's so far from what I've seen more so on the overdoses themselves, which is obviously important. But do we measure addiction purely on that? And so yeah, that's a huge spectrum, and it makes sense textbook wise because of the craving side. If something is approaching the craving, it's higher on the food chain of the mechanistic food chain of how it could work there. Quite the frontier that might be there after the weight loss scenarios too. So.